This conference will now be recorded.
Good morning, students. Am I audible? Okay, am I audible?
Yes, sir.
Okay, thank you so much. So today we'll be taking the topic esophagoscopy and bronchoscopy. So whenever there is a foreign body or whenever we need to check in the esophagus or in the bronchus, so we have an instrument, we do a scopy. So we keep an endoscope and see for the pathology or see for the structures inside these. So esophagoscopy is again divided. It is of two types. One is a flexible fiber optic and one is a rigid one. So the ENT people mostly go with the rigid one. So we mostly use the rigid one. And the flexible is generally used by the medical gastroenterologist. So they do it to see the stomach also. It means they go up till the stomach, but we generally go up till only the lower esophageal sphincter. So I hope you are able to see the screen. So these are the instruments which we use. The on the left hand side, the rigid one. So these are various, as you know, the esophagus has a lot of constrictions, right? Anatomical constrictions. We have, means the total length of the esophagus is 40 centimeters. That is from the incisors. So so the longest one is about the 40 centimeters. Means from the incisors till it will reach the lower esophageal sphincter. Doing a rigid one, we never go past beyond the lower esophageal sphincter. We just go up till the lower esophageal sphincter only. So the smallest one will be at least 25 at least around 25 centimeters. Means when from the incisors till at least 25 centimeters, we will be seeing the upper esophageal sphincter. So the smallest one will be around 25 centimeters, and the longest one will be around at 40 centimeters. And these are the instruments. Okay, so these are the suction cannulas and these are the instruments, the scissors or the grasping forceps or whatever you say. So these are the instruments very long enough. Similar instruments will be also used in laryngoscope, but they will be short enough. Okay, so the shaft will be around something only up till here. Okay, if the shaft is up till here only, then it is a these instruments are used in laryngoscope. When the shaft is around 40 centimeters in length, then it is they are used in esophagoscope. Okay. So this is the rigid esophagoscope. This is the fiber optic. You can see this is the fiber optic and this is flexible. So this can generally the tip is passed from the nose. Okay. So from the nostril. These are passed from the oral cavity. The tip passes from the oral cavity and it will reach the lower esophageal sphincter. But the tip of the flexible fiber optic will will be passed from the nose, and with the help of the swallowing maneuver, the patient will generally swallow it, and it will help. This tip will be reaching the upper esophageal sphincter. Flexible can be done in the local anesthesia. The patient is just asked to drink some local anesthetic, and that will the patient can go ahead with this procedure. But previously, generally, rigid esophagoscopy is done in general anesthesia. But in 1980s, 90s, some surgeons who were very well versed with this technique, they used to do it with the same local anesthesia also. But nowadays, we generally don't prefer. We prefer a general anesthesia to do a rigid esophagoscopy. So I hope you have understood the difference between the rigid and the flexible. Now going through it. So this is how, if you want to do an X-ray of a rigid esophagoscopy, this is how it will look. So the optimal patient positioning derives from the insight of physicians working in collaboration with SWOT swallowers. So as you might have seen in some circus and all, some people swallow the whole SWOT. So that is not any magic and all. It's a pure science. They know the esophagus, means they know how to push the SWOT into the esophagus. That's it. So they are not that's not at all a magic. It's just a pure science. So see, this can be done how? when you extend your neck like this, when you have when you extend your head and neck like this, means a flexion here. There's a flexion here, and you extend the neck here. The oral cavity comes in line with the esophagus. So this is how, see, the sword is getting swallowed here, and once it is in alignment with this upper esophageal sphincter, this can be slowly pushed into the esophagus. Okay. So this is at the lower esophageal sphincter. This is the upper esophageal sphincter. 15 centimeters. Okay. So from the incisors till the upper, it is 15 centimeters, right? So yeah, a sword of 40 centimeters length can be easily pushed from the oral cavity till the lower esophageal sphincter without any problem, if you have the technique. So this technique is, if you know this technique, you can do this magic. Okay, there's nothing in it. So what are the indications? Indications of any scopy are divided as diagnostic and therapeutic. So you can do this procedure for diagnosis purpose, or you can also do it for a therapeutic purpose. So what are the diagnostic indications of esophagoscopy? For any cases of dysphagia, for any cases of odynophagia, regurgitation, when there is a blunt trauma to the neck with associated subcutaneous emphysema, when it's a penetrating neck trauma, or when the radiographic evidence of esophageal mass or a stricture, caustic or a foreign body ingestion, when there are some congenital anomalies or vocal cord palsies. So all these are the conditions where you can go for an esophagoscopy. So these are all just a diagnostic purpose. We are going to diagnose by doing an esophagoscopy, whether why the patient has a dysphagia, why the patient has pain while swallowing, why there is a regurgitation, whether there is some problem at the upper esophageal sphincter or the lower esophageal sphincter, when there is trauma or foreign body. So all these conditions you diagnose by doing a rigid esophagoscopy. Also, when there is suspicion of aerodigestive malignancies, secondary involvement by autoimmune or idiopathic disease, mechanical obstruction, neuromuscular disorders. So all these are, so when a question comes to you that what are the indications of esophagoscopy, you divide it into diagnostic and therapy. And under diagnostic heading, you can write all these conditions. If you remember at least 4 or 5, that's more than enough. Try to remember dysphagia, odynophagia, regurgitation, trauma, for congenital anomalies, foreign bodies, suspicion of malignancy, and mechanical obstruction. So these are some of the most common causes where esophagoscopy has to be done. Then what are the therapeutic indications? Foreign body is the most common. Okay, adult, we generally have meat or bolus. Sometimes a chunk of bone with the meat is will get stuck into the esophageal musculature. Then you have to go for esophagoscopy. So foreign body is the most common cause where we have to go for esophagoscopy, and in adults the cause is meat bolus. In the children, most commonly the coin, or it can be a battery, it can be anything. Okay. And the most common site to get lodged is cricopharynx. Cricopharynx is the most common site where the foreign body lodgement is generally seen. So how to manage the case preoperatively? Assessment of the cervical spine instability. As you have seen in the picture, that the extension of the neck is there, and the of the head, and the neck flexion at the atlanto-occipital joint is there. Okay. So if the cervical spine instability is there, the patient cannot extend the neck like that, and you cannot reach the upper esophageal sphincter. And you also have to check for the loose or capped teeth or protuberant teeth, because while doing esophagoscopy, if you're not careful enough, you might damage that tooth, and that tooth might slip into the esophagus. So that will again be a foreign body. So you have to check for this. And a contrast examination to delineate anatomical abnormalities like cervical osteophytes, diverticulae, or a pre-stenotic dilatations or tumors. So generally, you should also go for a barium swallow before going a esophagoscopy. So while doing a contrast, you will get to know cervical osteophytes or diverticulae or the pre-stenotic dilatations. And plain chest radiograph is generally done to rule out any gross cardiac abnormalities. Example, massive cardiomegaly. If there is a massive cardiomegaly, the esophagus will be shifted to one side. So you need to be very careful. If you you're not careful and you directly reach the esophagus, and if you puncture it, then you might injure the mediastinum and the heart also. So before doing esophagescopy, we have to definitely go check for the cervical spine instability. We have to check for the tooth, loose tooth, barium swallow is done, and a plain chest radiograph is also done. So generally, the procedure starts with we have to induce the patient. We have to keep the patient in general anesthesia. Then the patient should be lying in supine position, and the position known as Boyce position. So there is minor neck flexion and the marked extension at Atlanto-occipital junction. So you have to remember this, okay? Boy's position is generally used in esophagoscopy, whereas in tonsillectomy and tracheostomy, and we generally use the patient in Rose position. So what is Rose position? We keep a shoulder, means we lift the shoulder by keeping a shoulder back, and we extend the neck. So that is you won't have this much marked extension, only a minor, only the shoulder is lifted up so that the oral cavity is totally visualized. So that is Rose position, and the Boy's position is minor neck flexion and marked extension at Atlanto-occipital junction. So you have to remember these points, okay? So this is the one which is generally asked in vivas. What is Boy's positions? And then you have to say that it is minor neck flexion and marked extension at Atlanto-occipital junction. And the position is maintained how? By using the forefinger on the palatal surface of the incisor teeth. So the palatal surface of the incisor teeth, you keep the forefinger, and you keep the third finger. With the help of the third finger, you retract the lower lip, and the position is maintained. Once the patient has been kept in Boy's position, you open the mouth with your non-dominant you open the mouth with a non-dominant hand. You keep your forefinger at the palatal surface of the incisor teeth, and with the help of third finger, you retract the lower lip, and that how you will keep the mouth open. And then you with the help of your dominant hand, you start introducing the esophagoscope, and you generally pass it from your right side. Means most of the surgeons are right-handed, right? Generally, if he's the left dominant hand, then you will directly do it from the left side. But generally, more surgeons will be right-handed, so you have to pass it from the right side, and the tongue is pushed to the other side. That is, the tongue is pushed to the left side, and the scope tip is passed from the right side, and it is advanced until uvula is visualized. So you have when after keeping the position in Boy's position, you with your non-dominant hand, what you do is you put your forefinger at the palatal surface of the incisor teeth, and the lower lip is retracted, and with that hand you keep the mouth open, and with the other hand what you do is you pass it from the right side, push the tongue to the other side, that is the left side, and you have to advance it slowly until you see the uvula from the esophagoscope. You have now, when you are passing, you have to see from the lumen of the esophagoscope only, and you have to pass it up till the uvula is visualized. And observation is maintained through the lumen of the esophagoscope at all times. This is to align the center of the lumen with the center of the observed field. So once you have started passing the esophagoscope into the oral cavity, you have to see through the lumen, and you have to pass until you see the uvula first. Then it is then lowered such that it rests on the thumb of the left hand. Means the esophagoscope should not touch the teeth. You have to keep the thumb over the teeth, and over that thumb only you have to keep the pressure. So at no time should the upper dentition be used as a fulcrum. You have to protect the upper dentition. So the pressure should be the esophagoscope should rest on your thumb, and your thumb should rest on the teeth. Okay, so there should be no contact between the teeth and the esophagoscope. I hope you understood. Then the thumb is used to advance the scope along with some minor rotatory movements from the right hand. So by rotating with the right hand, your thumb should guide your scope. Now the thumb should be guiding your scope. The scope is then advanced into the hypopharynx off center such that it should be possible to visualize the right reepiglottic force and the right piriform fossa. So once you have reached the uvula, you keep the esophagus resting on your thumb, and you slowly guide it towards the larynx first. Means first you try to visualize the larynx. Once you once you know that this is the larynx and this is the area epiglottic foot, then you directly raise it towards the piriform fossa. You introduce your esophagus towards the piriform fossa, and then the scope is advanced into the piriform fossa, right piriform fossa, and swept into the midline. Then it is means you are on the right side initially, but once as you enter the piriform fossa, you have to bring the scope into the midline. You have to push it to the midline, such that it comes to lie behind the posterior lamina of the cricoid. Actually, just hold on for a second. I'll just show you the picture of ideal picture. That will make this. Are you able to see this picture? If you're able to see, this is how this is now you're at the epiglottis level. So the esophagus scope is at the epiglottis level, and you will. So this is the one of the piriform sinus, and this is one of the piriform sinus. Okay, so this is the right side, this is the left side. Sorry, this is the left side, this is the right side. Okay, so this is the right piriform fossa. So what you do is you introduce the tip of your esophagoscope into here, and once you're you have passed this piriform sinus, then what you do is you push the esophagoscope into the midline. Means you will try to bring the esophagoscope into the midline such that it lies posterior to the cricoid. So here is the cricoid bones, right? This is the cricoid cartilage, and this is the postcricoid area. So you have to reach the posterior of the cricoid, so that you can go into the esophagus. Here the direct laryngoscope or the esophagoscope up till here it is common. In the direct laryngoscope you will be reaching till here and you will be taking a biopsy or any foreign body located here. But if you want to take the foreign body, or if you want to see the esophagus, what you do is you you guide your tip of the endoscope towards the one of the piriform sinus, whatever whichever you feel feel that it is easy to go. So you direct towards one of the side of the piriform sinus, and once you have entered the upper esophageal sphincter, what happens is you have to push your endoscope towards the midline, such that it reaches posterior to the cricoid. So the tip is advanced by small rotatory movements and left thumb pressure until pulsating indentation of the aortic arch is identified. So the scope is then advanced into the hypopharynx off center such that it is possible to visualize the right AE fold and right piriform fossa. Scope is then advanced into the piriform fossa and swept into the midline such that it comes to lie behind the posterior lamina of the cricoid. Cricopharyngeus now becomes visible. Gentle dilatory pressure is maintained until cricopharyngeal relaxation is achieved and tip passes into the cervical esophagus. So you have to keep the tip of the esophagoscope just near the cricopharyngeus. So what that will do is it will gently relax the cricopharyngeal muscle, and that will open up the cervical esophagus. Then the tip is advanced by small rotatory movements and left thumb pressure until pulsating indentation of the aortic arch is identified. So the aortic arch indentation is at around 25 centimeters. Okay, 25 centimeters from the incisors. So up till you have to pass it up till you see that aortic arch indentation. At this point, the esophagus will curve anterolaterally to the left, causing difficulty in advancement. Means when you reach that position, aortic arch, due to the presence of aortic arch, the esophagus will be pushed anteriorly and laterally. So you have to direct your esophagus and anterior and laterally. So you have to remember all this. Means how to proceed. Once you are into the oral cavity, you have to proceed towards only one side, or either right side or the left side. You have to see the uvula first, then you reach the larynx. Once you visualize the larynx, you have to guide towards one of the piriform sinus, and once you reach the piriform sinus, the tip of the esophagus will stimulate the cricopharyngeus muscle to get relaxed, and once the cricopharyngeus muscle is relaxed, the cricopharynx opens and upper respiratory sphincter opens, and you can enter the esophagus. And how do you enter? You have to once you enter the esophagus, you have to keep it midline, and you have to guide the esophagoscope until aortic arch indentation. Once the aortic arch indentation is identified, you have to move your esophagoscope anterolaterally so that to move into the middle cervical esophagus, middle thoracic esophagus, sorry. Once you reach the upper cervical esophagus, aortic arch will be there, and once you pass the aortic arch, you have to go anterolaterally and reach the mid 1/3 of the esophagus. If the patient is kyphotic, then it requires realignment of the axis by extending the back. To grasp the foreign body during esophageal jaw of the forceps are opened after they have been inserted beyond the tip of the scope. Means the forceps will be passed through the esophagoscope, and once when the jaw is opened, the jaw of the forceps are opened after they have been inserted beyond the tip of the, means when it is in the esophagoscope, the jaw is not opened. See. So this is the esophagoscope. Okay, you are able to see the instruments used in the esophagoscope. So this is the jaw. Okay, so this is generally not opened. It has to be closed until it is in the esophagoscope. Once the this tip has passed the tip of the esophagoscope, then what you do is you open it up. So if to grasp the foreign body during your rigid esophagus, jaw of the forceps are opened after they have been inserted beyond the tip of the scope. If the foreign body is too large to be withdrawn through the lumen of the scope, it is then advanced to shield foreign body. You have to pass this forceps beyond the foreign body and try to push it. Means it should not go further down. It should be pushed back. So you have to pass the esophagus beyond the, not the esophagus. No, you have to pass the instrument beyond the foreign body and try to shield the foreign body and slowly push it towards yourself, towards the outside. And sharp objects should be sheeted or rotated so that the point trails. Means if it's a safety pin, what you have to do is you have to grasp the forceps with the help of the sharp end and try to rotate it like that. Means it should that sharp one should come into the esophagoscope, not it should not touch any of the mucosa of the esophagus. A blunt foreign body may be held tightly against opening of the scope and withdrawn simultaneously in plane of least resistance. Foreign body may escape if scope is advanced over a foreign body that is surrounded or obscured by granulation tissue. So you have to be very careful. When a foreign body may also escape if the scope is advanced over a foreign body. Means due to means a long, if it's a long standing is foreign bodies, what happens is granulation tissue will be forming. granulation tissue will be formed over it, and you may not visualize the foreign body. So if you're not careful enough, what you can do is you can pass the esophagoscope beyond the foreign body, and that may also lead to escape of that foreign body. So how do you follow up the patients after endoscopic removal of the esophageal foreign body? We observe the patients, we observe it until sedative to wear off at least 4 hours and clear fluids for 6 hours post NBM. Reinsert endoscope after object removal to rule out perforation. And you need to follow up a barium swallow in adults, not necessary in children unless esophagitis is present and the risk of stricture. So you have to give the patient NBM till 6 hours. You have to again reinsert the scope after removal of the foreign body to rule out perforation, and you need to follow up by doing a barium swallow. What are the complications? Well, fatal airway obstruction. The patient can go into transient apnea. The coin displacement to the main bronchus. Means while bringing out, if by chance if it the grasp means the foreign body, the forceps which you are using, suddenly you lose the grasp of the foreign body and it is pushed into the bronchus. Means you took it out from the esophagus, and while bringing out you lost it into the larynx. So the coin can be displaced into the main bronchus. Esophageal perforation can occur. Esophageal tear can occur. Perforation is total. All the layers of the esophagus are teared, and there is an opening into the mediastinum. But esophageal tear is only only the upper layer, only the serosa layer or the soft tissue layer is opened up, but the muscle layer are intact. So that is esophageal tear. Pneumomediastinum can occur. Air can escape into the mediastinum. Bleeding can occur. Missed second point. Sometimes only one, only a part of the foreign body is removed, and sometimes a part of the foreign body is retained. Foreign body lost in nasopharynx. Sometimes if it is in the nasopharynx, you cannot take it from the by doing the esophagoscopy, right? So sometimes the foreign body is lost in the nasopharynx while removing. Aspiration pneumonia is seen. What are the X-ray signs of possible perforation of the esophagus? So the perforation of the esophagus is one of the most dreaded and the most common complications that occur. So how do you understand? How do you get to diagnose? We do an X-ray after doing esophagoscopy. It is mandatory to get an X-ray chest done. It is mandatory. So when you see the air in cervical soft tissue or subcutaneous or supraclavicular mediastinum, so you can suspect that there is some perforation in the esophagus. Pneumothorax, pleural effusion, retropharyngeal swallowing. So all these swelling. So all these can have to, if they are present, then you can suspect a possible perforation of the esophagus. So you can see there is some air here in the cervix, in the prevertebral area. You can see some air shadow here. Some air has escaped towards here. So all these are the prevertebral air from hypopharyngeal perforation. Now, what is bronchoscopy? So bronchoscopy provides the precise anatomic information about the intraluminal anatomy, mucosal characteristics, and dynamic process of the aerodigestive system. And it can be diagnostic or therapeutic procedures, providing a direct view, tactile information, and capability of manipulate tracheal or bronchial lumen. So this is a bronchoscope, okay? So you can see there are vents here. So these vents are required to infuse air because the patient has to breathe, right? So we are using some of the lumen of the trachea and bronchi. So we have with this lumen, the air is pushed into it. And this is the endoscope which we used. This endoscope is passed from here. The endoscope is passed from here. Some of the instruments can be passed from here. This is the port for oxygen. These are the bronchoscopes you used. This is the instruments used in the bronchoscope, and these are the endoscopes. What are the indications? Diagnostic use, biopsy of the tumors within the main airway is the diagnosis purpose. Therapeutic treatment of massive hemoptysis by cold saline lavage or placement of a Fogarty catheter to occlude the airway. Sometimes to remove the foreign body in infants and small children, and aspiration of insipiated secretions. So the bronchoscopy is generally done more of a therapeutic use. Diagnostic is generally biopsy, or sometimes a foreign body. Limitations: observing or treating beyond the right or left mainstem bronchus. So when you do a rigid bronchoscopy, you cannot pass beyond the right or the left mainstem bronchus. Lesions of the cervical spine who cannot hyperextend neck. So when you cannot hyperextend neck, bronchoscopy cannot be performed. And lesions of jaw who cannot open the mouth wide. If the mouth opening is restricted, you cannot pass that will not help you. So these are the limitations for both esophagoscopy and bronchoscopy. Rigid bronchoscopes are compatible with both carbon dioxide and flexible laser applications and are non-inflammable. And pediatric bronchoscopes should contain side channel ports allowing passage of narrow bone bore suction catheters. Dormia urologic stone baskets or side channel alligator or cup forceps while maintaining ventilation, visualization, and illumination during procedures such as biopsies or retrieval of foreign bodies. So while removing foreign bodies or while doing a biopsy, Dormia urologic stone baskets means the urologist used to remove some of the stones, right? So the basket's name is Dormia baskets. So these baskets are used to in pediatrics. Means if it's any secretions are there or some structures which are easily breakable. So what you do is you pass these Dormia baskets inside first, and then you collect it in that basket, so that none of the material, it's not a part of a single part of the foreign body or biopsy is retained there. You have to remove everything. So pediatric bronchoscopes contain side channels. They also have another port to allow these suction catheters or Dormia stone baskets. Diameter. In outer diameter of the scope is pediatric is 4.2 to 8.2 millimeter, whereas in adult it is 9.2 to 14 mm. Procedure is generally done under GA. Direct laryngoscopy is performed first to avoid missing laryngeal or pharyngeal lesion. So when you are planning to do a bronchoscope, initially, whenever you do a esophagoscopy or bronchoscopy, first a direct laryngoscopy is done. So that is the it's a mandatory one. You have to first visualize the larynx. You have to see whether any lesion is at the laryngeal surface of epiglottis or at the AE folds or at the glottis area. If there is no lesion, then you go for a esophagus or bronchoscope. So rigid bronchoscopy performed using an open tube bronchoscope containing a Hopkins rod telescope to provide magnification and distal illumination, or a side channel light carrier and a proximal magnification lens. So measures before bronchoscopy, it is generally a team effort. Senior ENT surgeon along with an expert anesthetist has to be there. A light and suction should be checked before procedure, and good venturi system means you have to maintain the oxygen level, saturation level. So you have to maintain the good, see whether the venturi system is good or not. Proper size, how to calculate the size of the bronchoscope. Size of the bronchoscope, if the patient is less than 6 years of age, then age in years plus 3.5 by 3. So these are some of the formulas you have to not required for you, generally required for a ENT surgeon, but just for your idea I'm telling you. So these are the proper size bronchoscopes. Always you have, this is the dictum, always second look for other foreign bodies in other bronchus. Okay. For suppose you know that there is a foreign body at the right bronchial level, so and you went into the right bronchus, you took that out and you came out, but you should also you should, that doesn't complete your bronchoscopy. It's better to go into the left bronchus also and to see whether any retained secretions or whether any retained foreign bodies are there also, because the procedure is you cannot do it again and again. So it's better, you all should always have a second look for other foreign bodies. This is how the inner and outer diameter and bronchus size according to the age. So how do you do? The patient's head and neck are initially placed in a neutral position. A tooth guard is used in adults to prevent injury to the maxillary teeth. A bronchoscope is oriented so that the bevel is oriented vertically and ventilation port is accessible to the anesthesiologist. So the ventilation port should always be accessible to anesthesiologist, so to pump oxygen and other gases, other anesthetic gases. Bronchoscope can be introduced directly into the oral cavity through a Jackson slide laryngoscope. Means initially a laryngoscope is kept, and through the laryngoscope opening you can also pass this bronchoscope. So you can see, so this is the bronchoscope which is being passed. Okay, this is the bronchoscope. This is how you pass. So rigid tube bronchoscopes being inserted into a patient's trachea. Note how the head and the neck must be hyperextended. You can see here there is a flexion of the neck and the extension is there. This is the extension. Introduced from the right side of the mouth, held in the left hand, used to steady and maneuver the maxilla and retract the lips. Later for instrumentation, left hand maintains stability and controls advancement of bronchoscope. Sweep the tongue to the left side and is advanced until tip of the epiglottis is visualized. Patient is head is extended related to the neck. The tip then passes in midline until it passes through the laryngeal inlet and vocal cords are visualized. Bronchoscope is positioned with the long end of the bevel parallel to the longitudinal axis of the vocal folds so that the long end of the bevel enters the glottis in the midline. So the bronchoscope should enter the vocal cords in the midline. Should pass gently through the abducted vocal folds. Once beyond glottis, scope can be rotated in any direction and camera is rotated in the compensatory function to maintain an upright view of the monitor. In infants and children, first expose the vocal folds using a sliding laryngoscope blade with an open bag such as Miller. Once scope is in trachea, ventilation port can be used. As further inserted, head must be positioned so that the tube corresponds to the axis of the lumen of the passage to be examined. Examination of the trachea and the bronchi should be performed in a routine sequence as it may affect bleeding, airway obstruction. Mucosal characteristics are continuously examined as the scope is advanced and withdrawn. Means as whenever you advance the scope or you take back the scope withdrawn, you have to observe the mucosa. Mucosal abnormalities can be subtle because of small size, minimal surface effects or obscure location. So you need to be very attentive and you have to be very careful observing the mucosa. Slight surface irregularity or friability may be the only visual clue to a neoplasm. As it's a very narrow space, if it's a very slight irregularity seen, then you have to go for a biopsy so that to rule out any neoplasms. Trachea and the bronchi are inspected for patency, deviation, configuration, and intrinsic lesions or evidence of external compression. So this is how it looks when you do a bronchoscopy. This is at the level of the carina. Okay, so you have already passed beyond the trachea and you're at the trachea. You're at the level. So this is the right bronchus, this is the left bronchus. As the scope approaches carina, patient head is turned to the left to allow scope to enter right main bronchus. So when you want to enter the right main bronchus, the patient head is turned towards left. When you want to see the left main bronchus, then you have to turn the patient head towards the right. To enter the bronchi, bevel of the scope should be turned in the direction of the bronchus to be explored. If you want to see the right bronchus, then you have to turn the direction of the scope towards the right side. First orifice within right main bronchus on lateral wall is the opening of the right upper lobe bronchus. When you enter the right main bronchus, in the first orifice which you see is on the lateral wall is the right upper lobe bronchus. Normal right upper left bronchus. Okay, so this is the normal upper left left bronchus. Scope can be stabilized just proximal to this subcarina and at a 90-degree telescope passed through the scope with its lens pointed laterally to visualize the apical, post and anterior segmental bronchi. Once the bronchoscope is in place at the subcarina, then you can pass a 90-degree telescope. So you can use a 90-degree telescope to just visualize the apical, post and anterior segmental bronchi. So as the scope passes through the bronchus intermedius, head requires some left lateral deflection and a considerable degree of lowering at the as the right middle lobe bronchus is identified and anterior with its lateral and medial segments. So as to see all the segments of the tracheobronchial, you have to use a telescope and you have to maneuver the head accordingly. If you want to see the apical segment, you have to turn it more towards the opposite side. If you want to see the lateral one, you have to slightly deflect the head towards the opposite mildly towards the opposite side. So accordingly, once you want to see each and every segment of the tracheobronchial tree, you have to rotate the head and you have to rotate the bronchoscope. So this all bronchoscope is then withdrawn just proximal to the carina. Patient head is rotated towards the right and scope is advanced into the left main bronchus. So when you want to see the right, you have to turn the patient towards the left side. When you want to see the left main bronchus, you have to turn the head towards the right side. So the same continues. Once you see the one side of the total bronchus, you have to see the other side also. So these are all the segments, as you might have if you have remembered some of the segments, then so you have to see the upper and lingual division. Then upper bronchus will contain apical, posterior, and anterior segmental bronchi. Lingual branches will contain superior infantile segmental bronchi. So you see all each and every segment here. You see, as bronchoscopy is being withdrawn at the completion of the scopy, careful retrograde examination should be performed. During pediatric scopy, telescope is connected to the ventilator scope by a locking bridge. Flexibility of the patient's neck and airway facilitated through examination using a 0-degree lens. Mass lesions, papilloma, and granulation tissue may be biopsied or completely removed if obstructing or pedunculated. If it's a pedunculated one, it can be completely removed. If it's only obstructing, then you can go for just a biopsy. And after the biopsy report comes, you can plan for the next management. Removal of the large sessile lesions, if present in a circumferential distribution, may contribute to subsequent stenosis. See, if you totally, if it's a circumferential distribution is there, and if you totally remove the whole one, then the chances of stenosis is more. Limitations: adequate neck mobility and stability, ability to open patient's mouth, damage to the teeth can occur. So these are the limitations of bronchoscopy. What are the relative contraindications? When the patient is hemodynamically unstable, when the patient has unstable arrhythmias, when there is increased intracranial pressure, when there is severe hypoxemia or hypercapnia, systemic coagulopathy, thrombocytopenia. So when the patient has all these conditions, it's generally contraindicated. What are the complications? Active bronchospasm can occur. The partial pressure of oxygen can fall below 70%. The positive expiratory end volume is more than 15 centimeters of water. Recent acute MI less than 48 hours. Unstable arrhythmia. Mean arterial pressure of less than 65 mmHg. Vasopressor therapy or a platelet count less than 20,000 mm3 or increased ICP. So these are the complications. These are the risk factors which can lead to complications. So if the patient has any of these, then if you perform a bronchoscope, then the chance of complications are more. What are the complications? The airway obstruction, drop in the partial pressure of oxygen, vasovagal reaction, fever, cardiac arrhythmia, bronchospasm, pneumonia, transient worsening in pulmonary infiltrates, pneumothorax, and if it's a chest malignancy, then bleeding can also occur. So these are the complications. I have made this PPT a bit more like for a PG one, but it can be helpful for you also. If you are interested, you can go through this. I'll just share this PPT with you once you again go through this. Okay, thank you. If anyone has any doubts, you can unmute yourself and ask, or else as the time is over 11:30, then I'll close the class. If everyone has your marked attendance, then I'll close the class. Thank you.